Uh, Good morning, everyone. I'm Ashu Tandon. I'm one of the imagers at Cleveland Clinic and Director of Cardiovascular Innovation. Our next session is focused on the late sequelae of transposition. My co-moderators, if you'd introduce yourselves.
I'm Diego Mogilansky. I do cardiac imaging and adult congenital in Florida.
I'm Ram Imani from Boston Children's Hospital.
And we're going to start out the session with a case presentation by Dr. Sneha Shahid. She's one of our excellent second-year fellows at Cleveland Clinic and wants to do EP. I know if there might not be a lot of EP people here, but keep your eyes open. So, all right, take it away.
All right. Thank you for the introduction, Dr. Tandon. So I'm Sneha. I'm one of the second years. I'll be presenting a case that exemplifies the late complications of TGA repair. I have no disclosures. So we have a 35-year-old female who had a postnatal diagnosis of detransposition of the great arteries, had a balloon atrial septostomy followed by a Senning procedure in infancy, also has known atrial fibrillation and atrial flutter with rapid ventricular response for which she was started on a beta blocker. A few years ago, she actually did have a syncope with subsequent motor vehicle accident, which prompted an EP study which showed inducible VT. She had an ICD implantation for that with an added advantage for anti-tachycardia pacing given her atrial arrhythmia history. For non-cardiac diagnosis, she has hypertension, elevated BMI, steroid-induced diabetes, papillary thyroid carcinoma, which was treated with radiotherapy with subsequent hypothyroidism. She presented to us with a chief complaint of dyspnea with exertion, and was found to have very poor functional capacity, very limited in ambulation, and also continuing to have intermittent palpitations. At this time, she was on metoprolol, enalapril, and furosemide. Her physical exam was notable for an elevated BMI, and then a new 2 out of 6 holosystolic murmur at the left lower sternal border. She had no overt signs of clinical heart failure. A cardiopulmonary exercise test was done, which showed moderate functional aerobic impairment, and the test was actually terminated prior to her reaching peak heart rate response because of fatigue. Because of limitation of transthoracic windows, a transesophageal echocardiogram was performed. This is a mid-esophageal 4-chamber view focusing on the systemic tricuspid valve, which, as you can see, is thickened. There's limited motion of the septal leaflet. There is mild prolapse of the anterior leaflet as well. The annulus here measured 3.3 centimeters. We can also see that the RV is mildly decreased in function. With color, there was moderate to severe regurgitation, which was medially directed. This is a 3D en-face view of the tricuspid valve viewed from the atrial side, again showing the same. And then with color showing that moderate to severe regurgitation. The pulmonary venous baffle was shown to be patent both in 2D and then in color views. There was no significant flow acceleration. The systemic venous baffle, both the superior and inferior limbs were also patent, and again with color showing no flow acceleration. You can see the pacer wire here as well. Another 4-chamber view, looking more closely at the RV function, which was mildly decreased, we said. A CT was done, which corroborated these findings. So we saw a patent superior limb of the systemic venous baffle. The pacer wire was seen here, and there was an unobstructed pulmonary venous baffle as well. So based on these findings, she did meet indications for intervention because of the symptomatic tricuspid valve regurgitation and RV dysfunction and symptomatic arrhythmias. So she underwent a tricuspid valve replacement with a 33 millimeter BioCore prosthesis and had a biatrial maze procedure with cryoablation. Post-operatively, she did acquire AV block requiring permanent DDD pacing. Otherwise had an uneventful recovery. In the short term, she had improvement in palpitations and dyspnea. In the longer term, however, she did develop pacemaker-induced dysfunction and is being currently considered for cardiac synchronization therapy or transplant. This is one of our more recent transthoracic pictures showing the prosthetic valve in place. There's mild flow acceleration to inflow, trivial regurgitation. Here's another view that shows the same, but you can see that there is now moderate to severe dysfunction of the RV. This is just a timeline of her management, with her undergoing her BS and standing in infancy and developing symptoms enough to require intervention in her mid-30s, and then now in her late 30s has the pacer-induced ventricular dysfunction. So this case highlights the progressive systemic tricuspid valve annular dilation and regurgitation, the progressive systemic RV dysfunction, and then the high incidence of atrial arrhythmias following the atrial switch procedure, not to mention the inherent risks of the operative procedure. I wanted to thank my mentors and thank you for listening.
Thanks, Anaya. That was great. So thanks, everyone. I'm going to talk about imaging the long-term sequelae of transposition. And my disclosures are I'm a consultant for one of the virtual reality companies that you'll get to see on one of the hands-on sessions if you swing by. So talking about the background, right? We're going to talk a little bit about various imaging modalities, their strengths and weaknesses. I think these are not foreign concepts to most people in the room. And then we'll talk specifically about what do we need to look for in atrial switch, what do we need to look for in arterial switches, and then some of the edge cases. And I think we've heard about a lot of these potential complications throughout the talk, throughout the sessions today. So, I think one of the most comprehensive views on what we need to be looking for was the multimodality imaging guideline in JACE in 2016. That was written by Dr. Cohen, who we had the pleasure of hearing from yesterday. And obviously, right, we have a number of different modalities that we can use to interrogate what's going on for these patients. Looking mostly at the technical part, I think everybody recognizes that echo is great for availability, portability, and it's safe with pacers. There's no radiation. So I think that's often our go-to modality. Cardiac MR, I'll admit I'm a little biased as a cardiac MR aficionado. And so most of the pictures you'll see are MR pictures. But I think, as Dr. Kovu mentioned, there are ability to image with pacers. It's obviously not portable, but the good news is there's no radiation and gets better every year. CT is becoming even more useful as well because the overall dose of radiation with each successive generation of CT scanner is going down, and it's fast, which is great. Nuclear is not something that I have a particular a ton of experience with, but it does come with it a fair bit of radiation. And then cath, I think the biggest advantage of cath is that you can inject the dye exactly where you want it to go to see specific structures and get the hemodynamic data. So I think in terms of looking at the atrial switch, there's specific things that we're trying to look for, right? We're trying to look for systemic venous baffles. We're trying to look obstruction. We're trying to look for pulmonary venous baffle obstruction, baffle leak, and RV dysfunction. And so I'm not going to go over the table because I think each modality has its strengths and weaknesses for each of those use cases. For the arterial switch, we're looking for supravalvular AS, supravalvular PS, branch PA stenosis, neo-aortic root regurgitation, and the valvular regurgitation. And then coronary artery disease, right? Coronary stenosis and myocardial ischemia. And there's a number of complementary ways to evaluate those, each of those complications that we're looking for. And I'll show some pictures of each of those. And then when we're looking at patients who underwent the Rastelli or Nikaido procedure, we're looking for residual VSD, subaortic obstruction, and then conduit obstruction and regurgitation. So let's focus a little bit on the atrial switch. So as we discussed, we're looking for baffle obstruction and leaks, and then systemic tricuspid regurg and RV dysfunction. So here's a patient that I scanned while I was at UT Southwestern. who had undergone an atrial switch. We thought it was a mustard. And you can see that there's both superior and inferior systemic baffle stenosis. So this is a cardiac MR done with faramoxetol, which is an iron contrast agent. And it gives us pretty nice pictures here of the superior limb being stenosed here and the inferior limb being stenosed. This is a patient that was referred from an outside hospital in the mid-30s, I think. And the main question was, what's the venous access? Because this patient had atrial arrhythmia as they tried to do an EP study and to try and figure out, but they couldn't access this patient's veins. And so we did an MRI here to look at the venous baffles. And what we also saw was that there's a significant amount of venous collateralization in the superior, especially in the right supraclavicular area. And this is a MIP, like a maximum projection image with a thickness, where you can see also that there's a bit of SVC occlusion, there's a bit of innominate vein occlusion. And then this is a 3D reconstruction of the abdomen of this patient, where there's a giant set of collaterals. And so the reason that they couldn't access this patient's groin was because all the groin vessels were gone. And so this is, these are decompressing veins, including one in the abdomen. And this might be a patient that Chris has seen. But there are enormous collaterals in the abdomen. And we didn't plan to image the abdomen, but once we saw what we saw above, we had to look below and see what was going on. We looked at the venous structures, and that was one of the advantages of this MRI contrast agents, that we were able to get a whole body image. So you can see there's this large dilated collateral. So here, moving on to baffle leaks. Moving on to baffle leaks, here's a pulmonary baffle leak, which you can see right here. It's pretty large. And I think MRI is one of the better ways of viewing this. I think echo also, if you are able to get the right angle with color Doppler, able to show these, depending on the size of it and the pressure, we often don't see a jet of leak on MRI, but we are able to calculate the QPQS. This one happens to be pretty large. Shown there. And then with some of the newer imaging modalities that exist in MRI, like 4D flow, you're able to see this baffle leak in this flow diagram. This is a picture thanks to Tariq Al-Said at Pittsburgh. So you can see that there's two-fro flow across this baffle leak. Here's a 34-year-old male with transposition who underwent atrial switch. And here we're trying to look for there's unobstructed venous return, but there is systemic tricuspid regurgitation. MRI is able to help us quantify that, which you've heard already. There's also a little bit of mitral regurg there in an eccentric jet. We also see a jet here of subaortic stenosis, so you can see that there's a kind of a muscle bundle there, and then a jet of dephasing from a residual VSD. Here's a 3D looking at 3D echo image, looking at systemic tricuspid annular dilation, thanks to my colleague Justin Treader, and moderate to severe tricuspid regurgitation due to this annular dilation. So let's talk about the arterial switch, right? We thought the main things we're looking for are PA stenosis, branch PA stenosis, neo-aortic dilation, and then coronary stenosis and ischemia. So I think everybody's seen pictures of the LPA stenosis post-Lecomte. You can do this with CT or MRI pretty well. This patient, the LPA, especially as it went over the aorta, got down to like 7 millimeters. Here's a patient who's a 19-year-old with conjoined corrector transposition, who's status posted a mustard, a gland, and an arterial switch. And here you can see that there's neo-aortic dilation. There's a little bit of flow disturbance through the valve, but more importantly, there's neo-aortic regurgitation, which you can quantify on MR. I want to spend a second thinking about coronary interventions. We talked a little bit about this yesterday already. Nick Suji, my colleague, talked about this a little bit. But really the main questions we're trying to ask is the tissue dead already, right? Because if it's dead already, there's no point doing revascularization. If the tissue isn't dead already, is there reversible or inducible ischemia, right? Is it a fixed perfusion defect, or does it happen at stress? And then, is there a feasible target for revascularization? So we try to answer these questions using a combination of modalities, but particularly MRI, to be able to say, is it worth going after this occluded coronary? So here's a patient, thanks to Tariq Hussain, my colleague at UT Southwestern, came for routine coronary angiography as a transposition. Here's an injection into the right coronary, and you can see it backfills to the left main, and there's left main complete stenosis there. So did an MRI. This is late gadolinium enhancement imaging. So gadolinium gets stuck in the tissue where it's there's fibrosis. And we saw that it looked pretty clean. There's 4-chamber and short axis image. So no, we're not already too late, right? This muscle is not dead yet. Nick showed some perfusion scans, but I'll go through this again just to show the way this usually works is you get a pre-bolus, it goes to the right heart, left heart, and then you do the full bolus, goes to the right heart, left heart, and then it goes to the myocardium. Here you can see this perfusion defect mostly in the left anterior descending territory, suggesting, and this is stress, so this would be mean stress. So there is a perfusion defect. Now, is it reversible or is it inducible? And so at rest, we don't actually see that same defect. So at stress, we see the perfusion defect. At rest, we don't. And the tissue is not dead. So so now going back to this angiogram, there looks like maybe there's a target where we could do bypass grafting into that left main. There's a segment there that we could target. So I think this is a patient that demonstrates that we have a good reason to think about intervening on the coronary. Here's a picture courtesy of Jeremy Steele at Yale as a CT showing, I think, a reimplanted circ. But this patient did have a fair bit of late gadolinium enhancement, suggesting that perhaps this was not a reversible defect at this point. But the nuclear stress that Dr. Steele did on this patient showed that there was a little bit of reversibility, but not in that spot, right? But there was a perfusion defect in the anterior wall of the LV. Now, it's been just a couple minutes talking about edge cases. So when we're thinking about Rastellis and Nikitas, we're looking at residual VSDs and subaortic obstruction. Here's a patient that we did, I think, a week ago, who this is a patient who underwent Rastelli and has this subaortic muscle, right? So this is the VSD being baffled over. You can see that there's flow acceleration starting well below the level of the valve, right? This is what we heard about yesterday, where the VSD actually becomes the subaortic pathway. The good news was that it wasn't particularly stenotic, but you do see some regurgitation there, and this is something we'll need to keep an eye on. Here's another patient where you can see kind of a longer tunnel, and then there's this ridge of muscle hadn't been seen on imaging before. So again, something that we need to keep an eye on. Here's a patient with depressed systemic RV function who had undergone a mustard and a right classic gland. And and you can see here's there doesn't seem to be much vasculature to the right upper lobe, as is common after the gland. Well, when we did this MRI, we saw a large azygous vein, which made me a little suspicious, as it will in any gland. And so we actually looked at the flow in the azygos and found that the flow is actually going down. So this is a decompressing vein from the gland going to the IVC system. And then we follow that up with a cath on this pressure injection. You can see these massive collaterals that are going down below. And it turned out that there was actually no net flow going to the right lung on MRI. It was all just going forward and then goes all backwards and down the azygos. So the gland part wasn't working very well. So in conclusion, I just want to say there's a multimodality approach for imaging these late sequelae. I'm biased in thinking that MRI can answer a lot of our questions, but I think there's a role for every imaging modality, especially given what exists at each center. But I think the main thing is that we have to be ready for surprises, right? We have to be able to think closely about what we're seeing and then be able to move on the fly and image as we go along. So thanks. Thanks to my colleagues and people who gave me all the pictures.
No, we'll have Dr. Brad Marino speak next about long-term outcomes and quality of life. And Dr. Marino needs no introduction, but is really a pioneer and thought leader in the field. So look forward to your talk.
Thank you. Good morning. I could literally spend 5 hours giving you this talk. I'm going to give it to you in about, I think, 18 minutes, and I apologize. So we'll talk today about definition of late and long-term outcome, cardiac-related long-term outcome issues, neurodevelopmental psychosocial outcomes, health-related quality of life, comparing kids with TGA to heart-healthy children compared to other types of CHD, and then we'll talk about the lack of recommendations for long-term follow-up. So, like my talk yesterday, I defined late outcomes to something that had looked at patients at a median follow-up of at least 10 years. For the purposes of this talk, I cannot discuss congenitally corrected TGA, the atrial switch with Steli and Nikaido, or the BREF operations. That, again, would take me 5 hours. So when we talk about cardiac-related long-term outcomes, we need to talk about survival, reintervention, and then very important residual lesions under sequela from intervention that Ashu already talked to you about. Residual stenosis of the RVOT and pulmonary arteries, neo-aortic root dilatation, neo-aortic valve regurgitation, and ascending aortic dilatation, coronary artery disease, chronotropic incompetence and exercise intolerance, and arrhythmia and sudden cardiac death. I'm going to show you one paper. There are literally a dozen papers that show these exact same results in literature now. We've been doing this operation for more than 40 years. This one from Frick et al. Had a median follow-up of 10.2 years. Mortality was 96.4% survival at 1 year. Post-op, 96% at 5, 10, 15, and 20 years. Freedom from reintervention, 94.9 at 1 year, and then 90, 89, 87, and 83 at 5, 10, 15, and 20 years. Reintervention was significantly higher in patients with TGA-VSD, TGA-VSD with aortic arch obstruction, consistent with what we talked about yesterday in terms of mortality rates and reintervention rates, than patients with TGA intact ventricular septum at 15 years. You can see the Kaplan-Meier curves. Bottom left is freedom from mortality. Bottom right is freedom from reintervention. And there are literally a dozen centers across the world now that have published this data. This is a very important paper from Villafane. These are the ACC guidelines from 2014 on TGA. Here, their table 3 really is a conglomeration of about 25 to 30 papers. Bottom line is the post-op sequelae include supravalvular pulmonary stenosis, approximately 10% of patients. It is the most common issue that needs to be intervened on. Supravalvular AS, less common, 5%. The second most common intervention requiring sequela. Now, the most common sequela are neo-aortic root dilatation and neo-aortic regurgitation, but the intervention rates are very low at this point, and we'll talk about this more as we get into later parts of the talk. Asymptomatic coronary occlusion is 2 to 7%, sudden cardiac death less than 1%, arrhythmia 2 to 10%, aortic dissection or rupture unknown. So I want to focus on a couple of these pieces specifically. Let's first talk about the neo-aortic valve, neo-aortic root. So freedom from neo-aortic regurgitation of grades 4, 3, and 2 are respectively 90%, 71%, and 20%. So at 23 years, a quarter century after you have your switch, only 20% of the patients will have less than mild to moderate AV valve regurgitation. So they'll all leak, but they're not leaking yet enough, at least with 25 years follow-up, that we need to intervene in a lot of patients. We'll talk about that. Risk factors for neo-aortic insufficiency include older age at the time of the ASO, presence of a VSD, bicuspid pulmonary valve, previous pulmonary artery banding, perioperative mild neo-AR, and higher neo-aortic root to ascending aorta ratio. Neo-aortic root dilation is very common, occurs as a consequence of the ASO, and is especially is prevalent in patients with a big size discrepancy of the great arteries. We talk about this all the time in surgical conference, and it bears out in the data. Aortic root dilatation has not progressed significantly during the current duration of follow-up at 25 years, nor has it been associated with acute aortic dissection or increased mortality. As you'll see in my conclusions, I think all the surgeons and the cardiologists in the audience should watch this very, very carefully in the next few decades, because I think that is going to change. Sorry for so much data on this slide, but even though coronary artery disease, or at this point, is a low incidence of 2 to 7%, it's really important, because if someone's going to get in trouble, if they're going to die, it's going to be from this. So coronary obstruction late after the switch is uncommon and is more frequently anatomic than physiologic currently. Freedom from cardiac events is about 92% at 22 years, and I found 4 or 5 studies that were pretty consistent with that. Selective coronary angiography is the gold standard, and Ashu just showed you beautiful angio for anatomic evaluation of the coronary lumen. From an imaging standpoint, Ashu again did a great job with this. Although associated with radiation exposure, ECG-gated CT angiogram provides excellent spatial resolution about the anatomy of the coronary arteries. As we discussed yesterday, I think it's really important that we start on a regular basis doing CMR, because we really need to look at myocardial viability specifically. Stress echo and CMR can detect regional wall abnormalities and at-risk myocardium. And when we talk about what's recommended, there's literally no recommendation right now for anything relative to MRI and viability, which I think is a problem for our field, and that we have to really start modifying the guidelines to make sure that that's included with the unbelievable ramp up of what MRI now gives us. Very important for the cardiologists in the room. Clinical evaluation, ECG and echo possess very, very low sensitivity for detecting coronary insufficiency. You will not see it on an exam, you will not see it on ECG, you will not see it on echo, and if you do, it's way late. Exercise stress test is a preferred modality for physiologic assessment, and then CABG is done in a very small percentage of patients. So, arrhythmia and sudden cardiac death. The other thing you'll die from after this operation is having an arrhythmia due to myocardial ischemia and dropping dead. It's a very low risk at this point, but again, the coronary issues that these patients will face in the next 2 decades, we're finally going to get there, because if you think about the first group of patients in 1985 and becoming standard of care by 1995 to 2000, all these patients are 25 to 35, maybe 40. They're all about to enter that golden 20 years while all the typical adult coronary issues now kick in abnormal coronaries that have abnormal distensibility. So late SVT, especially atrial flutter or fib, is associated with RVOTO and or significant TR. Late VT may be scar-related or secondary myocardial ischemia and is typically amenable to ablation therapy. And then the incidence of late sudden cardiac death is, again, very low, less than 1%, and it's usually secondary to either primary arrhythmia, myocardial ischemia, and or infarction from coronary obstruction and or neointimal proliferation. All right, I'm now going to move to long-term outcomes relative to neurodevelopmental psychosocial care. I would be remiss if I didn't pause for a second and thank Jane Newberger and David Bellinger for starting the Boston Circulatory Arrest Trial in 1989. These patients are now 26 years of age. Jane and now Michelle Gervitz at Boston have followed these patients for literally almost 35 years now. And this trial was really the beginning of a whole era of individuals like myself who started looking at neurodevelopmental outcomes in children with complex congenital heart disease. Many of you probably don't know this, but back in 2011, Jane convened about a dozen of us in Boston. She had some philanthropic money and got the first nidus of the group together that ultimately would form the Neurodevelopmental Outcome Collaborative. But all the data that I'm going to show you moving forward, this is that trial that really told us everything we currently know about what happens when you're a young adult and a teenager relative to neurodevelopmental outcomes. There are smaller cohorts. There are cohorts that are multi-center, like the SVR trial, for example, but those patients are much younger. So when we talk about long-term outcomes, this is the data. So all of our babies that are born with congenital heart disease in utero, in the 3rd trimester, their brains don't grow normally. that when the brains are born at 40 weeks gestation, they typically have the gestational age of a 35 weeker and the brain maturity of a 35 weeker. There are tons of placental issues that are also ongoing in these patients that clearly impact brain development. They have altered cerebral blood flow and oxygen delivery in utero, differences in how the cerebrovascular resistance and what their brain flow is as a result. They have specific environmental exposures, not just from placental impact as well, and this all delays brain maturation, and 1/3 of these babies are born with white matter injury at birth. They have surgery. While I know all the surgeons don't think this, some surgeons still think that bypass is for free. It is not for free. Another 1/3 of these babies will have new white matter injury after their operations, and now 2/3 of these babies leave the hospital with white matter injury. Going on bypass inflames the brain. Inflaming the brain makes that the oligodendrocytes do not proliferate and differentiate normally, and as a result, you don't get the normal connectome that all of us get, and the brains do not develop normally over time, and a lot of these babies, not necessarily transpositions, but Fontans, have smaller cortical thicknesses and clearly have very significant issues relative to their connectome. So now you have all this acquired white matter injury and abnormal microstructure and decreased connectivity. Lots of things impact it. How much hypoxemia you had, for how long, additional surgeries, do developmental interventions improve it? Unclear. Drug exposures with narcotics and benzodiazepines in the OR and the ICU. Home environment, SES, clearly impacts your neurodevelopmental outcome, and there are clearly susceptibility genes that impact what you will look like phenotypically given a particular brain injury when you're a baby. And all this results in neurodevelopmental disability. Now, I want to be clear, half the children that will have a switch will be normal. I'll say it again. Half the babies will be normal, but half the babies won't. And that's a big percentage of our children. So what's the phenotype? If you look at normal distribution for all of us in this room, there's a bell-shaped curve. Cardiac intensivists are at the bottom of the curve, just joking. 2.5% are high, 2.5% are low, 95% is normal. In a cardiac baby who's had bypass in the first year of life, take that and move it to the left. So now 30% are low, 70% are normal or high. So 10 times the normal rate of having a lower IQ. Same thing for academic achievement, math, and language. They've decreased visual motor integration. So if you're a first grader and you're looking at a piece of paper your teacher gives you with three circles and a square, you look at those 4 images. You put them on your occipital cortex and you move them in space to say circle, 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 square. Well, if you can't do that well, then you can't understand the difference between a B and a D, or a C and an E, or an N or an M. Your sight words come later, you speak later, you tell stories later, and from a language and from an ability to engage in language, you get really behind very fast. It also impacts your math ability. There's impaired working memory and processing speed, impaired programmatic language, poor executive functioning, inattention, increased impulsivity with a much higher incidence of ADHD, and diminished fine and gross motor skills. These individual deficits or delays may be mild, but often occur across multiple domains. This high prevalence, low severity picture does not meet the classic criteria of a learning disability. In the 25 states represented at this conference, every one of your states has a different set of boxes that defines a learning disability that will allow that child to get the resources that they need in school. Many of these children have difficulties in school but may not qualify for the services as a result. There's a specific psychosocial phenotype as well, which is equally, if not more important. These kids typically have social cognition issues. When they enter a conversation with another child or with their adolescent friends or as young adults, they're not getting the same inputs and they're not processing the information the same way in terms of social cues. As a child, it may be isolated play. In adolescence, it may be bullying. And then as a young adult congenital patient, it may be that you have a very small social circle and you're not integrating your community as well as you could or you would like. 3 times a higher incidence of autism, an increased incidence of psychiatric disorders, specifically much higher incidence of anxiety, depression, post-traumatic stress in both the child and the parent. These are the original guidelines that came out in 2012. Bill Maley and I were the co-chairs for it, first of its kind. We're now rewriting these guidelines, Erica Sood and myself. The new guidelines will be out in about a year. Since that time, this is a year after Jane convened us in Boston. CNOC was created in 2015, the Cardiac Neurodevelopmental Outcome Collaborative. If you are not part of it and you're a center represented here at this meeting, you should join it. There are now more than 60 programs that are part of CNOC. I'll be talking more about this tomorrow. CNOC has come out with their additional guidelines, specifically for kids that are birth to 5 years of age and kids that are school age. And I want to thank Jeff and Cardiology in the Young for being our journal for CNOC. All right, let's get to quality of life now. So to make you all laugh, when I was a first-year fellow at CHOP back in 1996, I was Gil Warnofsky after clinic across the street at the bar. Yes, we're at the bar after clinic. And I had a napkin, and I was talking to him about, I was getting a master's at the time at Penn in health services research and clinical epidemiology. And I said, Gil, there's no measure to actually quantitatively assess quality of life in kids with heart disease. And I literally wrote what you see here on this slide on a piece of paper. And I went back on a very old Mac, and I created this conceptual model, which really has guided my science for the last 20 years and has really impacted how we think about health-related quality of life in our field. So we know that kids with CHD have various disease complexity. They have various medical, surgical, and catheter-based procedures. Very few of them die today. Less than 2.7% nationally. At the best programs that are here, less than 1%. 99% generally are surviving. We talked about with TGA, 2.5%, TGA intact septum, VSD 5%, aortic arch, probably 7-8% mortality. So even the TGAs, 92% of them for sure are going to survive. You have neurodevelopmental, psychosocial, and physical morbidity, and it impacts your quality of life. So basically for 10 years, I worked to create a disease-specific quality of life measure for kids with congenital heart disease. Quality of life measures your physical health and physical functioning, your psychological functioning, and your social functioning. And it describes a child's ability to function in situational contexts and derive personal satisfaction from doing so. You'll notice that your brain impacts all three of those specific focus areas. Here's our first paper, 2010, with the validation of the PCQLI, the Pediatric Cardiac Quality of Life Inventory. In the PCQLI, there's a disease impact subscale for physical health and physical functioning. There's a psychosocial impact subscale, max score 50, that looks at social functioning and psychological functioning. Total score is 100. A higher score is a higher quality of life. So back in the 2000s to 2015 approximately, in 16 US sites and 3 UK sites, we enrolled more than 3,270 families with 6,540 respondents, patient-parent pairs. To date, this is the largest quality of life behavioral assessment ever performed in a pediatric chronic disease, and it's garnered a lot of important data for us, and we've learned a ton. First, quality of life in CHD survivors and kids with TGA is lower than heart-healthy children. Quality of life in CHD survivors worsens with increasing disease complexity. Increasing medical care utilization is associated with lower quality of life in CHD survivors, and there's a wide variation of quality of life score within cardiac subgroups, including the TGA groups that we talked about, TGA, TGA-VSD, TGA with aortic arch obstruction. So this is from a paper from one of my fellows from 2014 in Journal of Pediatrics, looking at 3 groups of CHD, mild CHD, biventricular CHD, and the Fontan group versus healthy controls with the PEDS-QL, which is a generic health-related quality of life instrument. And you'll see that patients with BV-CHD, where transposition sit, was lower than kids with mild CHD that did not have a cardiac intervention, and lower than healthy controls and better than Fontan's. Now, let's go down and let's look deeper into the CHD population. This is data that you're seeing for the first time. We've submitted this to the World Congress. Not been shown before. When we pulled this data on these 2,500 families, we basically pulled every family that had a child with congenital heart disease to get all the acquired patients. And we basically tried to figure out how can we make them into specific groups relative to their quality of life, their quantitative quality of life. So the study design was a corollary study based on the PCQLI data study. Patients were 8 to 18, with their parents were reporting. PCQLI testing sites, all 19 were included. We looked at the PCQLI total score and then the disease impact and psychosocial scores. I'm not going to go through the methods in detail. Bottom line is we did a latent class analysis. The groups were derived from the patient's primary cardiac diagnosis and the medical history. We included cardiac, neurologic, psychologic, and cognitive data. 1,482 CHD patients were included. Average age was 12 years of age. And we created 4 complexity groups based on the latent class analysis. A mild group, a moderate 1 group that transposition sits in, a moderate 2 group, and a complex group. I don't want you to get bleary-eyed looking at the slide. I'll make this fairly simple. Here's the primary diagnosis. So in this mild group, you have VSD without intervention, bicuspid aortic valve without intervention, aortic stenosis without intervention. The probability that these groups would be in this mild group class are right here, and you can see all of them clearly sit in this group. I want you to look down here, group score. These patients had no stroke, one had a seizure disorder, 32 had learning disability, so 0.5%, 15.9%, 1.5% mental health problems, and no CAS, no surgeries, and no cardiac-related hospitalizations. This is your best cardiac group. Moderate 1 group, VSDs with intervention, transposition, TED alone, AS with intervention, and what we found was, again, probability 0.58 to 0.76 of these would be in this moderate 1 group. And you can see now we're increasing seizure disorder to 2.8%, 18.6 for learning disability, 3.2 mental health problem, and now they have at least 1 cath, 1 cardiac surgery, and 2 cardiac-related hospitalizations. Moderate 2 group, coarct VSD, pacemaker with biventricular CHD, AV canal. Yes, coarct VSD, a pacer, an AV canal, you have a lower quality of life than the moderate group I just talked to you about. And for those of us that take care of these patients, some of these patients are the bane of our existence in terms of how we care for them and how long they're in the hospital. And this was not surprising to me. And you can see here now we're up to 3% seizures, 29% learning disability, 6.1% mental health problems. And now instead of being 111, we're 1 cath, 2 surgeries, and 3 cardiac-related hospitalizations. And then no surprise to anyone, the TEP pulmonary treatment and the Fontan patients are the worst. So I went into the PSQLI data set. I pulled out just the TGA patients. And they sit here in the moderate 1 group. So again, this is just looking at the patient's total score and the parent total score. And you can see as you go from mild to moderate 1 to moderate 2 to severe, the scores drop dramatically. Now, if we go to TGA specifically, I'm sorry, I'm still here with the 4 groups. Now we're going to look at the subscale scores. Here's the patient disease impact, the patient psychosocial impact. Here's the parent disease impact. Here's the parent psychosocial impact. Again, as you go from mild to severe, the scores drop, and these are all statistically significantly different. So now let's look at TGA. So I pulled all the TGAs, about 250 TGAs from this cohort of 1,400 patients. And here's patient PSQLI total score, patient disease impact score, patient psychosocial impact score. Here's parent total score, parent disease impact score, and parent psychosocial impact score. And for the left side here is TGA intact septum. The right side is TGA VSD. Same thing here, intact septum, VSD. And in every one of these analyses, the TGA VSD patients were lower than the TGA intact ventricular septum. So there's no question whatsoever there was a disease-specific instrument that patients with TGA VSD will have a lower quality of life than TGA intact ventricular septum. All right, so what do the recommendations tell us? And this is from the ACC recommendations and then the ACHD US and UK recommendations from Dr. Somerville, Dr. Warrens, and then Juan Villafane from 2014. Every 1 to 2 years, these patients should be seen by an ACHD doc for their adult congenital care. From an imaging standpoint, they say echo at least every 2 years for assessment and follow-up for an EOR, aortic root dilatation, RVOTO branch pulmonary artery stenosis. There's no specific recommendation for MRI at specific intervals, which again, I think is something we have to correct as a field based on what we talked about the last 2 days. From an ECG and Holter standpoint, at least every 2 years to assess for chronotropic impairment, atrial and ventricular arrhythmias, exercise stress tests at least every 2 years to assess for chronotropic impairment, ventricular activity and arrhythmia, and myocardial ischemia. And of note, if there's osteostenosis identified in a child, annual ECGs and echoes with advanced cross-sectional imaging is indicated. Early and late onset ND abnormalities are common. Follow the guidelines. Neonatal coronary manipulation, potential endothelial stress, and ongoing aortic root pathology make coronary risk factor management very important as they enter their 4th, 5th, and 6th decade relative to their obesity, dyslipidemia, hypertension, inactivity, and smoking reduction. And finally, all 3 of them said the aging ASO patient may benefit from an exercise prescription rather than restriction. So in conclusion, longer-term survival is excellent. This is the tour de force of our field. I started training in the early 90s to see where we are now 30 years later, and the success that our surgeons, our cardiac intensivists, our nurses, our anesthesiologists, our cardiologists have had with this population truly is the greatest thing we've accomplished as a field. Freedom from intervention is greater than 87% at 20 years. I mean, that's unbelievable. Residual lesions and or sequelae from intervention include commonly RVOT and pulmonary arteries, aortic root dilation, aortic valve regurgitation, ascending aortic dilation, rarely coronary artery disease currently, chronotropic incompetence, exercise intolerance, and arrhythmia and sudden death currently. And again, I think in the next 3 decades, we need to be looking at that. In the next 2 decades, carefully watch for the roots, the valves, and the coronaries. Early and late onset ND and cyclostory abnormalities are common. Follow the guidelines. Quality of life in TGA children and adolescents are worse than those children with healthy hearts and mild CHD, and better than those with Fontan. In a latent class analysis, TGA, health-related quality of life, was assigned to the moderate 1 group, consistent with VSD with intervention, AS with intervention, cohort without VSD, and simple TETs. And it's better in those with TGA intact ventricular septum compared to those with TGA VSD. And finally, individuals with TGA should be followed indefinitely at a center that specializes in the care of patients with ACHD every 1 to 2 years. Thank you for your time.
Brad, that was great. Next, we have Joanna Gobriel, is a director of adult congenital heart disease at Cleveland Clinic.
Hello, everyone, and good morning. I think it's still good morning. And thank you, Dr. Marino, for actually saying that these patients need to be very closely followed in ACHD. So my topic is interventions in adult congenital heart disease patients that have had transposition of the great arteries and whatever kind of surgical repair. I will say again, as Dr. Marino mentioned, these patients need to be followed long-term and very closely in an adult congenital heart disease center. They have a lot of late sequela, and maybe there is freedom from reintervention, as Dr. Marino mentioned, that is greater than 87 at 20 years, but that does decline at 30 and 40 and 50 for sure. Transcatheter interventions, I feel like it's more of a big Band-Aid. What we do is really good Band-Aids to bridge these patients to their next surgical intervention or to their next transplant, okay? And importantly, also, as Dr. Marino mentioned, is we make these patients feel better. It's improved quality of life as well, which is really important, although maybe we do need to do a quality of life questionnaire on these patients. And I cannot emphasize how important it is to have a multidisciplinary care for these patients. So oftentimes when we're discussing one of these patients, it's not just us. It is ACHD. It's going to be also your EP doctors, your congenital surgeons, your transplant surgeons, your anesthesiologists, your pulmonary hypertension, all in the same room to figure out what is the best plan for one patient, because they are highly complex, and that's very important. So some of the interventions that I'm going to talk about include and are not limited to the following: baffle stenosis, stenting, which Dr. Tandon showed beautiful images of, baffle leak closure, RVOT PA branch PA stenting, transcatheter pulmonary valve or transcatheter aortic valve replacement, systemic valve and ring or valve and valve replacement, and coronary artery osteostenosis and anastomotic site stenosis. I have not yet seen a lot of patients that develop the heavy usual plaque burden CED patient in my clinic yet. Now, what I'm going to do is essentially kind of walk you through some of the patients that I see in ACHD clinic and the interventions that they need to go through and the history they've been through already. So this, for example, is a 36-year-old female, DTGA, mustered in 1985. SVC and IVC baffle stenosis, sick-sinus syndrome, atrial arrhythmias with multiple EP ablations and devices. The last one was epicardial. She has mild to moderate systemic RV dysfunction and mild AV valve regurgitation. She already had an SVC baffle that was stenotic and stented in 2010, and it was actually one of our ACHD EP doctors that called me and was like, hey, this patient, I couldn't get my equipment through. She must have IVC baffle stenosis. Can you take care of her? And that's exactly what we ended up doing, and you see here the IVC baffle stenosis, and ended up with a stent with improved actually diuresis and resolution of her lower extremity edema. This is another one patient, which is a 42-year-old female, DTGA mustered in 1981, baffle leak, and actually had a redo to ascending in 1985. Again, atrial arrhythmias with ablations, again, sick-sinus syndrome with a single lead pacemaker. She has significant PH on pulmonary vasodilators. She has moderate to severe systemic RV dysfunction and mild to moderate systemic TR. Now, she came in with a very swollen face that was red, so facial plethora and difficulty diuresing, and she clearly had SVC baffle stenosis. Now, when we discussed her, she already has a lead in that SVC. So the question is, are we going to jail that lead, and is that going to be okay long term? The fact that she had such advanced systemic RV dysfunction was something that we wanted to think ahead of time, thinking she's going to require transplant sooner rather than later. So we're like, fine, let's jail the lead. She's not requiring that much pacing at this point. And we did do a covered stent in here, and she had improved diuresis, and she's currently on the heart transplant list. So this is a different patient, 40-year-old, DTGA, mustard in 1982, moderate systemic RV dysfunction. This patient had an IVC baffle stenosis in the past and already been ballooned. And when I came to see him, he was having exertional symptoms. And when we do a metabolic exercise stress test, which is part of the guidelines of how to monitor these patients long-term, he did have a desaturation with exercise. And you see here, this is right here is the baffle leak. And we ended up closing that baffle leak with an Amplaster device with resolution of his exertional hypoxemia and improvement in symptoms. Now, sometimes they'll have both. They'll have both baffle stenosis and baffle leak at the same time. This patient was a slightly more complex. It's a 45 DTGA mustard in 1977, sick sinus syndrome, and heart block. Atrial arrhythmias, again, you guys are getting the gist of these patients, kind of a recurrent theme with atrial arrhythmias and a dual chamber pacemaker. Moderate RV dysfunction, so not severe, and mild systemic TR. He came in with blue lips and a red face, and he had SVC baffle, severe stenosis, and a large leak that was leading to right to left shunting. He's also 99% VPACE. Now, if you look at these CT images, they're not as fancy as Dr. Tandon's, but you see here that there's two actual leaks. There's one right here and a larger one here. And there's also an SVC baffle stenosis where a lot of the contrast is pooling here and it kind of narrows down right at that spot as it enters the systemic venous atrium. So part of the discussion of this patient is what is the best way to treat this patient, right? He's not going to require transplant soon, but he's also had open heart surgery. He may require transplant in the future. How do we preserve or minimize how many median sternotomies this patient would get? And again, with multidisciplinary care, we decided that we were going to do the following: extract his lead with laser extraction, then put a covered stent that will treat both the baffle stenosis and the baffle leak at the same time. You get 2 for 1, and then we're going to replace the leads. And that's essentially what we did. But with a few other additions here, we wanted to do embolic protection for the brain. So we added a sentinel device. And obviously, he is 100% pacer dependent. So he had a temporary pacer from the left femoral vein. This here, what you're seeing here is the laser lead extraction. What you're looking here are TE images, and you're seeing the very, very tight SVC baffle with the lead through it, and you see acceleration of flow, but you're also seeing the baffle leak with bubbles crossing from one side to the other. And the same down here. This is just demonstrating again that we had to place the stent in a very precise place, right? We did not want to impinge on your subpulmonic AV valve, but we also wanted to be able to cover the stenosis well and cover both leaks. So this is just a positioning of how this stent would end up going into. And then here is the end result. You have resolution of your leak, you have resolution of the stenosis, and this patient ended up doing much better, had the device replaced afterwards with a 3-year follow-up. I actually just saw him literally 2 weeks ago in clinic. And he did want me to share with all of you a picture of his t-shirt that says battery powered. Now, sometimes what we do to the patient actually can cause some problems, okay? So this is a patient with, she's 33, CCTGA with a double switch. So mustard and Rastelli repair in 1993. Now, she had SVC stenosis and ended up with a stent appropriately, but that was in 1995, so she was much smaller at the time. She then subsequently had an RVP conduit replacement in the year 2000. She had, again, atrial arrhythmias and non-sustained VT and has a pacemaker and ICD placed. She came in with classic SVC syndrome. And as you see on the CT, this is her SVC. It's quite dilated, and all this dark material is a big, large thrombus around the lead. If you look at this image right here, you see that that stent at that distal end is also stenotic. So stent stenosis and a large clot. So what we ended up actually doing in this case is we went in and aspirated the thrombus with the NRA flow retriever system. This is how much clot we got out of that SVC. And then after that, we just angioplasty with a cutting balloon and a high pressure balloon, that SVC stent. We just wanted to minimize that, another open heart surgery for this young woman. She's doing much, much better. I don't have the post-CT because this literally just happened, honestly, a few weeks ago. So we'll be getting the post-CT later. But from a clinical perspective, she's doing great. Now, moving gears a little bit, this is a 29-year-old gentleman with DTGA with a VSD, had an arterial switch and LeConte, and he had a subsequent aortic valve replacement with severe prosthetic AS, and to the point of the importance of follow-up in ACHC clinic, he was lost to follow-up for years. And then he shows up with an EF of 20%. So at that point, there was a discussion of, so what do we do to decrease his surgical risk? Do we take him to the OR? Can we do a TAVR? And in that case, a TAVR would merely be a bridge because he's only 29. This kid is going to require more than one open heart surgery in the future. So we ended up going with TAVR, and thankfully, actually, his EF improved to 50% on his 6 months follow-up. And this is a method of, this is bridging. We're bridging him to the next intervention that he's going to be needing. And as with aortic, we move to pulmonic valve. So this is a DTGA patient who had a Rastelli repair. She had had 2 BTT shunts and then the Rastelli in 2003 and a redo in 2011. So already multiple open heart surgeries. And she came in quite symptomatic with severe pulmonary valve regurgitation and moderate stenosis with a peak creatinine of 50. Here you're seeing the angio demonstrating wide open PR across that conduit and then after valve and valve replacement. This is an intracardiac echo image just demonstrating that very thickened, shortened valve leaflet, the biprosthetic valve, and that color is showing the severe PR. And this is post-valve placement with resolution of PR. This was actually a case I was involved in when I was a fellow, so a long time ago. This is a 52-year-old DTGA mustard who had her initial surgery at 13 months, had a residual VSD, closure of the VSD at 7 years old, baffle leak, closure percutaneously, and then systemic AV valve with a ring at 49 years. And then we decided that in order to save her another open heart surgery, because we were thinking, again, transplant evaluation, we did kind of bench testing of a valve in ring deployment, and this is what she ended up getting, which is a transcatheter valve replacement into her ring, and she actually did much better. Now, there's other potential forms, I think, that are not in commercial use per se. There's obviously the mitral clip, which is going to be quite different when you're using that in a systemic AV valve, which is a tricuspid valve with 3 leaflets with not the same outcomes. And there's all these new technology like the AccuCinch, the mitral line, and all other new valve platforms that are still, again, not in commercial use. But I think this is something that we should definitely be looking into in the future for these patients, again, using these devices as a bridge to what is next they're going to be needing. And lastly, and Dr. Marino covered this also beautifully, is these patients, you have to have very high suspicion. It is not the first or last time that I see a 42-year-old woman that comes to me and says, I went to the ER multiple times saying I have chest pain, and they told me it's all just anxiety. And it was not anxiety. She was having true angina. She did have a floridly positive stress test, and she did have severe left main stenosis and ended up with left main stenting with resolution of symptoms. So all in all, in conclusion, these patients post-atrial or arterial repair require close monitoring in an adult congenital heart disease clinic. They have multiple late sequelae, and they do need very close evaluation. Transcatheter interventions are very efficient. They can be used to medically optimize these patients, bridge them to either a future surgical repair or future transplant, and you minimize how many redo surgeries they get, and you make them feel better, which I think is important. Multidisciplinary care is critical for all these patients, and we've already discussed some of these interventions. Thank you all.
Thank you, Dr. Gabriel, for that excellent talk. Next, I'd like to invite Dr. Christine Gulasarian. She is the head of congenital heart surgery at Medical City Dallas, and will be talking to us about safely establishing cardiopulmonary bypass.
Thanks, Ram, and thanks for the remainder of the moderators. Ashu, it's good to see folks that I worked with before, and thank you all for the invitation of getting back up on the podium. So I know everybody knows this, but I think it's also important just to highlight the fact that 1975 was nearly 50 years ago. And I hope I'm doing that math correctly, but the arterial switch operation or retransposition of the aorta and the pulmonary artery was actually meant to reestablish normal circulation as you can get. And I think everybody knows that the anatomic correction rather than the atrial level switches have done well for our families over the year. I think what people may not know are that Dr. Jatain had 4 children, 3 of whom became cardiac surgeons and 1 an architect. And I'll leave it up to you as to who you all think might be the smartest of the 4. Here, Jeff, go ahead and take your picture. Okay. Okay. Anyhow, an anatomic and physiologic correction of DTJ, as I mentioned, first performed in 1975, with the idea that patients would be free of future re-intervention. And I think that was the case with a lot of the early corrections of many of the congenital heart defects. But I think you've seen from the previous talk, and everyone in this room knows very clearly that that's not always the case. But the idea was that since no prosthetic material was being employed for the operation, that perhaps all of these structures would grow without any problem at all. However, within a few years, in the late 1970s, supravalvular pulmonary stenosis developed in a not insignificant number of these patients, requiring revision of the initial neopulmonary reconstruction. And as a result, like in anything that we do when we attempt to tackle a problem and make it better, we usually do. However, the long-term complications which you have seen, including coronary ischemic syndromes, coronary artery stenoses, neo-aortic regurgitation and root dilation, supravalvular neo-aortic stenosis, and branch pulmonary artery stenosis are things that we see in addition to probably the most common, which is the supravalvular pulmonary stenosis. And a lot of this has to do with underlying coronary artery anomalies and where we position these coronary buttons. Sometimes there's neo-aortic to ascending aortic anastomotic mismatch, and there are lots of things that we can do to try to make that mismatch a little bit better. And then, of course, there are some patients who've had pre-arterial switch, prior to the arterial switch, have had pulmonary artery bands. So some of the reoperations that we see, and thankfully these are infrequent, include neo-aortic valve repair, semilunar valve replacement, neo-aortic root replacement. I think David Barron, you're going to be talking a little bit about that a little bit later today. Conduit replacement in the instance of RV outflow tracts that needed to be augmented with a conduit at some point. Coronary artery arterioplasty and bypass, which I think Brad Marino is warning all of the surgeons in the audience to beware of down the road, in addition to the neo-aortic root. Aortic arch reconstruction in cases of DTGA, VSD, and arch reconstruction as neonates. And then for the catheter-based interventions, we've seen aortopulmonary fistulas that have occurred after stent dilation of the supravalvular pulmonary area, and pulmonary artery aneurysm or pseudoaneurysm repair, arrhythmia surgery, and then probably cardiac transplantation, which all the surgeons in the room would say that's sort of the best one, because we don't have to worry about maintaining the underlying operation that we tried so hard to perfect. So how best to avoid these complications? I like to say, this is my mother, honey, why didn't you just do it right the first time? And I think a lot of us, we do try to do it right the first time, but there are some anticipated and unanticipated complications that will arise down the road. There's plenty of literature that I don't want to delve into right now, but I think suffice it to say, we've had over 40 years now of follow-up in lots of these patients, and we're finding out new things that we maybe not necessarily understood when the arterial switch was first being employed. But suffice it to say, too, as Brad pointed out, the proportion of patients who are free from reoperation sort of dwindles with the complexity of the underlying repair and as time goes on. Coronary button transfer, I think it's important for us, before we even think about establishing bypass, to actually understand the operation that was done before. Sometimes we reoperate on our own patients, but a lot of times we're being referred patients or inheriting patients who have come from elsewhere, or we're switching programs and inheriting those that have preceded us. So understanding how the original operation was done is critical. Reading operative notes, I take intraoperative pictures of every operation that I do, videos, et cetera, can be helpful, but really just understanding the principles. So I think a lot of folks yesterday understood how we create a medially based trapdoor flap, or the closed technique with coronary reimplantation. Ultimately, you end up with this, something, you have the Lecomte maneuver, bringing the pulmonary arteries anterior to your neo-aortic reconstruction. But the point is, you have multiple anastomoses, multiple suture lines. You could have an aortic suture line, the two buttons, you've got your reconstruction of the neopulmonary root, and then the pulmonary anastomosis. And all of those are at risk of having scarring, some early and some late. When you look, I think this is a principle that was trickled down from Aldo Castaneda, and that was mobilization of the branch pulmonary arteries all the way to the hilum. And that's just a technique to help reduce the risk of supravalvular pulmonary stenosis, as well as elongating the posterior neopulmonary root reconstruction. Because again, you've got your aortic suture line and these buttons that are lying right behind. What you want to end up with, I hope, is something like this, where you have pulmonary arteries anterior to your aorta with nice flow, no stenoses, no high velocity jets. Again, when we take this LeCompte down. That is the key point in any part of reoperative. Well, I should say, in operating on the knee aortic root, you've got to take this LeCompte down. You have to be able to cannulate the aorta. You can see there's an aortic cannula up through here. This is a really nice diagram, but we don't always have the luxury of having so much ascending aorta. Additionally, when we think about delivering cardioplegia, we have to remember that some of these patients certainly have aortic insufficiency, and we need to be able to provide adequate myocardial protection. And I think David's going to talk about that even more. But that last diagram, this is the normal coronary anatomy. So we create anomalous aortic origin of the coronary arteries every time we do this operation. But there are complex coronary anatomic arrangements that can create variations in that type of setup. So you need to be aware of those before you get in there. So the single coronary artery may have a tunnel-like reconstruction. The intramural, usually the coronary buttons are kind of rotated a bit. And in this case, you can see that sometimes the coronary arteries are implanted in a much higher position. All of that matters when you're talking about reoperative surgery after an arterial switch. But before you even establish bypass, you've got to have safe sternal reentry. Many folks, including myself, will leave a Gore-Tex membrane or some other type of membrane. You can kind of see that right here, and make our incisions a little higher just so we can have exposure to the suprasternal area to be able to cannulate the innominate artery and vein if we get into trouble. Gore-Tex membranes, I've sometimes used a silastic strip, the very same type of silastic that we use to leave a chest open, or MPA band, but you can put your sternal wires in and just lay about a 1 centimeter long strip on top of the posterior sternal wires, and then close your wires over that, and then you can just at least have a safe sternal reentry. And some people use core matrix. You can see sometimes on the scans this membrane. This is a beautiful retrosternal space, but it's not always the case. In fact, most of the time you have a situation where you've got adhesions or a very dilated heart immediately adjacent to the sternum. This is the stuff we've been talking about supravalvular pulmonary stenosis or the branch PA stenosis. Sometimes it can be, there can be compression between adjacent structures. And depending on the underlying anatomy, if you've got dextrocardia, it may not be the branch pulmonary artery that you think. And then with regard to coronary arteries and the proximity to the sternum, I think even Chuck Frazier might agree that CT scan is probably a good idea for these patients for their preoperative evaluation, which brings me to preoperative planning. So CT scan, ultrasound, a lot of these, depending on when you inherit the patients or when you reoperate on the patients, they may have had multiple catheter interventions or multiple diagnostic cardiac catheterizations or just multiple lines that are in place. So it's imperative that you know what vessels are open so that you can plan. Access with your anesthesia team, with the perfusion team. And I think, as Joanna pointed out, having a multidisciplinary approach to every single patient is really critical, because there may be some things that we can do that are outside the box. For cannulation and for the cardioplegia strategy, it really depends on the underlying situation. If it's supravalvular pulmonary stenosis and you've got an aortic valve that functions well, then you probably are able to carry out cardiopulmonary bypass in the standard way, as long as you can get to the aorta or get to the innominate artery, but and then deliver cardioplegia maybe a little bit higher than normal and have strategic clamping. But when you have aortic insufficiency, you then have to think about selective antegrade cardioplegia, or in the instance of coronary stenoses, retrograde cardioplegia. So all of those things make a difference. When we're talking about concomitant aortic arch reconstruction, then we want to make sure that we're anticipating the need for selective cerebral perfusion, or in some instances, circulatory arrest, depending on the clinical situation. Of course, blood products, appropriate monitoring, and EKG, intraoperative EKG mapping are very helpful and have really aided in the success of these procedures. I mentioned already extension of the sternotomy incision for exposure of the suprasternal area. We have to anticipate adhesions, the usual ones or the ones that are associated with infection or mediastinitis that always make it more fun. And then for patients who do have pulmonary artery stenosis, that may be longstanding, aortopulmonary collaterals should be at least thought about. So careful mediastinal dissection prior to establishing bypass. And here, I think we showed this yesterday, we've learned, from our aortic arch reconstruction, either with single ventricles or in complex arch reconstructions, that selective antegrade cerebral perfusion can be a helpful modality. As I showed before, taking down the LeCompte is really critical if you are dealing with the aortic root. Now, supravalvular pulmonary stenosis, that is the most common thing that we see. So here, in these, like I said, in these diagrams, it makes it look like we have plenty of aorta, but that's not always the case. But mobilization of this anterior pulmonary artery is really critical to be able to cannulate the ascending aorta, and then standard venous cannulation. And then in terms of the types of repair, it can be a patch, just an anterior patch, or a more geometric patch with filling the areas that we see with patches of either bovine pericardium, or if there is any remaining autologous pericardium, that would be the first choice. And then there are various degrees of branch pulmonary artery stenosis that may need to be addressed. There are other case reports of some more unusual types of postoperative complications, like a pulmonary artery aneurysm with tracheobronchial tree compression. You can see here the pulmonary artery looks to be about normal size, but when we take a look through here, you can see that there's compression of the branch pulmonary arteries. And in the retroesternal area, this looks a little bit daunting for those of us who have to saw through that. So you just got to be careful. Always have the option for neck access, groin access. You can see here, I think this is a really nice depiction of the sort of the mid to distal tracheal compression, as well as left mainstem bronchial compression from an MPA aneurysm here before and after the repair. Now, neo-aortic valve regurgitation with root dilation. David, I'm not going to jump into your talk, but it is the second most common indication for reoperation, or it may become more of that. And there's plenty of literature out there as to these types of complications that we see, and I think to be determined how we're going to be dealing with them. But certainly neo-aortic valvuloplasty following the arterial switch has been described, as well as more complicated repairs like a Bentall. And in this case, you've really got to get access to the aortic root. So take down that Lecomte, and also sometimes just you may need to divide the branch pulmonary artery to kind of flip that pulmonary root out of the way in order to get exposure to the posterior neo-aortic root. So in conclusion, keep calm, do it right the first time. So try to do it right the first time. Try to anticipate the complications you might have, and try to listen to your intraoperative imagers who are telling you that there is a problem. Don't think it's going to go away. Usually doesn't. Fix it when you can. There are anticipated and certainly unanticipated complications. They will occur, no matter how good we all think we are. But I think it's really best to address them as soon as they come up. Use a protective barrier for safe sternal reentry, and make sure you understand with your team, the OR team, cardiology teams, the intensivists, everybody, get your preoperative imaging, understand the type of access, have a plan A, have a plan B, discuss with your perfusionists the cannulation strategy, the myocardial protection strategy, and the intraoperative surgical strategy. And I don't mean during the timeout. This is something where it's really good planning will usually lead to success. So thank you.
We are running about 30 minutes behind, and I hear a lot of stomachs growling. So I will try to keep my talk a little bit on the short side. A lot of this has already been covered, and I'm going to talk a little bit about surgical challenges after an atrial switch. And this really encompasses several cohorts of patients. There's this sort of group that we've been talking about after atrial switch for detransposition of the great arteries. And then there's the population of patients who are now becoming more common. This is a repair of congenitally corrected transposition of the great arteries. And the raging debate back in the time was, is ascending better or is a mustard better? And I wasn't there for a lot of those conversations, but this was quite a raging debate for treatment of patients with detransposition of the great arteries. And the frequency of the sending procedure and the mustard procedure sort of went in this pendulum type of format where for some time people were favoring one versus the other. So you'll probably see a pretty even split of the two types. And I think it is important to understand the subtle differences between the two types of atrial switch when you're thinking about dealing with the complications. Earlier, we heard about transcatheter treatment for systemic venous pathway obstruction. I'm not going to say a lot other than to say that, as was previously mentioned, typically there are collaterals that develop from the upper pathway down into the lower pathway. And here you can see almost a well-developed azygous vein that's decompressing the SVC. This obstruction typically occurs at the SVC to RA junction. This is where the bend of the pathway occurs, and that's why it's a very common location for obstruction. And so of course, the transcatheter treatment definitely manages to open up the pathway. I will comment on differences between catheter-based management and surgical-based treatment. I do worry about compliance, and think about a compliance a lot when we're dealing with patients who need a good long-term outcome. And one of the issues that we face when we put plastic throughout the entire venous pathways is what happens to the compliance of that atrial chamber, particularly if you put a stent that then occludes or obstructs the atrial appendage, which is probably the only remaining compliance chamber in the atrium at this point. So when we're thinking about whether to put a stent in to manage obstructions or whether to go to the operating room, I like to have imaging that gives us a sense of where are the key structures located, where is the atrial appendage, where is the coronary sinus, and how much true atrium is there in this pathway. Pulmonary venous obstruction typically occurs in both the Senning or the mustard type, but the mechanisms of obstruction of the pulmonary venous pathways are slightly different. With the mustard type reconstruction, you have a single sort of baffle that brings the SVC and IVC down to the more posterior AV valve. And the obstruction occurs because that pathway is a little bit more bulbous and is larger than usual. And sometimes you can see aneurysms of the SVC or IVC limbs, and this leads to impingement upon the pulmonary venous pathway, which basically travels around the limbs of that systemic venous pathway. In the Senning procedure, the mechanism is slightly different. In the Senning, we're sort of creating a pathway by reconstructing the atrial septum. And then the pulmonary venous pathway is this incision in the anterior portion of the pulmonary veins. And that opening anterior to the pulmonary veins serves as the outflow from the pulmonary venous chamber to the more anterior AV valve. Depending upon whether it's a CCTGA or a DTGA, that's a different valve. And this pathway can be narrowed if it's not done just right. And so this can be the source of pulmonary venous obstruction. And the treatment of that is to essentially enlarge that pathway. You may have to make incisions onto the individual pulmonary veins. In some situations, making an incision in the pathway from the anterior chamber down to the pulmonary veins and placing a separate pericardial patch may be necessary. In surgical treatment of either pulmonary venous obstruction or systemic venous obstruction, there can be calcification of patch material that's placed. And so one really needs to know that well. I typically get a CT scan before going in to get a sense of the calcification, because one might go in to simply patch open a previous atrial pathway but end up in a hard rock, and now you're really revising the entire pathway. Calcification can occur in both autologous pericardium as well as other materials. It can occur if there has been an infection in the past, and so you want to think about endocarditis of these pathway structures as well, and make sure that you're not dealing with an old infection that could still be harbored. So this is an example of how the pulmonary venous pathway is treated after the Senning procedure. Here there's the opening of the pulmonary venous pathway, which is this incision anterior to the pulmonary vein. And the treatment may require a further incision into the individual pulmonary veins to enlarge that pathway. Part of the reason why I prefer the mustard procedure over the stenting is there's pretty decent transcatheter management for systemic venous obstruction in the setting of a mustard, but if you want to treat pulmonary venous obstruction after a stenting, really the only way to manage that is surgical. There's really not effective transcatheter treatment for this. So that sort of weighs into my decision making now, mostly in the CCTGA population. But we learned a few things from the old treatment of DTGA. Baffle leaks were alluded to earlier, and they can be more common with the mustard procedure because there are a couple of areas of tension that one encounters in placing the venous pathways. And typically, these lead to desaturation, even if there is left to right or bidirectional shunting. There's always some degree of right to left shunting during part of the cycle. And so many of these patients, regardless of the net direction of the shunt, will come to you with a desaturation. So it's essentially creating a mixing lesion. In terms of the surgical treatment of baffle leaks, these occur very commonly at the bends in the pathway, and you can sort of see here the various twists and turns that a pathway needs to take to make it down to the posterior AV valve. And those are the areas that are under the highest tension and can be the source of dehiscence of a patch. In addition, there are frequently trabeculations in the atrium, which may not be obvious immediately after a procedure, but then eventually enlarge and lead to intramuscular atrial baffle leaks. Another challenge that we face is the management of arrhythmias after the atrial switch. The data that we have on this population are mostly for treatment of DTGA. And the incidence of atrial arrhythmias after atrial switch was fairly common, with 50% incidence at about 15 to 20 years. Most of these are supraventricular tachycardias, and atrial flutter being the most common. But there can also be sinus node dysfunction. We don't see as much of the atrial arrhythmia issue so far at really midterm follow-up in the CCTGA population. Not quite sure why that is. May have to do with the fact that your systemic pumping chamber is a left ventricle. But there are accessory pathways that patients with CCTGA can harbor. If we have a patient who's presented with some degree of a supraventricular arrhythmia prior to going to the double switch, we prefer to map and ablate those ahead of time because very frequently those accessory pathways are located in around the mitral annulus, and those will no longer be accessible or easily accessible to you once you do the double switch. So we would recommend ablating those before doing the double switch procedure. There are several important considerations for ablation, particularly with regard to location of the pathways that need to be ablated. And there are several important lines. One is the atriotomy sutural line. One is the line of anastomosis for the IVC and SVC limbs. And ablation is fairly successful. It often requires puncture of the systemic venous pathway to get to the area of reentry, but it's successful in about 70 to 80% of patients. So there are a subset of patients who we have to address these arrhythmias potentially in the operating room, and these can be pretty challenging to identify. In this population, we've started to do more intraoperative mapping to identify the area of reentry so that we can more effectively target and ablate these particular lesions. Another important problem, particularly in the CCTGA population, that we're going to start facing as we move forward is the management of complete heart block, and how do we sequence these patients. It was very telling in our analysis of the patients of CCTGA, and as I mentioned earlier, the risk factors for left ventricular dysfunction after the anatomic repair was the placement of a ventricular pacemaker. And it was clear that the dysfunction was more pronounced in patients who had just a simple dual chamber pacemaker. And so we've gone to doing a primary CRT device in many of these patients. Now, if you're going to put in a pacemaker in a patient who's had an atrial switch, this obviously starts to beg the question, should we be placing a transvenous system or should we be placing a surgical system? We've had a little bit of a debate in our institution related to this. Obviously, the location of the coronary sinus becomes very important. Most surgeons, when we're doing the atrial switch, unroof the coronary sinus so that we bring the coronary sinus into the systemic venous pathways. But not every surgeon does that, so that you may have some variability in terms of the location of the coronary sinus for transcatheter CRT device placement. But more importantly, you know, we've seen, and Joanna also showed the incidence of SVC baffle obstruction and the impact that having transvenous leads has on the pathways, the potential for thrombus development. And so for this reason, one has to really think carefully about how to manage heart block in a patient with an atrial baffle. Should we place it transvenous, or is it worth making a smaller incision to place a CRT device epicardially? Again, one of the issues that we've talked about earlier after atrial switch is for CCTGA is the development of left ventricular dysfunction. And we were alluding to a little bit of this earlier. And one of the problems that can develop late after an atrial switch in the CCTGA population is LV dysfunction. It's something that we're going to start seeing more of. And it appears to be due to not only muscular dysfunction, but also potentially due to inadequate blood supply and inadequate neovascularization of the muscles. So this is something that we're going to see. I alluded to earlier the issue of the non-compliant systemic venous pathway, and this is something that we've been paying more attention to. You know, a patient with an unobstructed pathway that comes back with a retrograde flow in the hepatic veins and a profile in the hepatic veins that just really doesn't feel right. And I think that this is something that we need to think about in the long term as we manage patients with the atrial switch. How do we create a compliant chamber? How do we still allow there to be some sort of an atrial kick? And is it worth revising the pathway in patients that present with evidence of right heart dysfunction or pathway noncompliance? I want to talk a bit about AV valve regurgitation in patients with DTGA, and this is obviously something that we talked a little bit about in the last session. I prefer to repair the tricuspid valve in this patient population. It's mostly due to ventricular dilation and papillary muscle location in the right ventricle is abnormally positioned such that any degree of ventricular dilation will lead to splaying of the tricuspid valve leaflets. And if you can reverse that, you not only help right ventricular remodeling, but you also may be able to provide for a better tricuspid valve repair. We don't have long-term data on that. It's, again, not a terribly common procedure, but it's clear that having tricuspid regurgitation is a risk factor for mortality, and several series have shown that. There may be a role for PA banding, as we've spoken about earlier. So I'll summarize by saying that obviously the atrial switch in long-term survivors requires careful monitoring, but we have to take some of the lessons learned from management of DTGA as we start to think about management of patients with CCTGA. And so as Chris was saying earlier, so we can do it right the first time. We have to really think about particularly how we manage baffle complications, heart block, and arrhythmias, and hopefully we can be smarter about avoiding the non-compliance issues that we sometimes face. Thank you very much.
Great. Next up, we have Justin Tretter from Cleveland Clinic. We'll talk about the unnatural history and advanced surgical planning for the dilated and dysfunctional neo-aortic root.
All right. No disclosures. So from the outset of birth, patients with transposition, they start off with larger than normal pulmonary roots, on average a Z-score of about plus 1.6. Then following the arterial switch, there's a rapid increase in the first year of life, both in the absolute value and the index Z-score value, followed by a linear increase, on average absolute value increasing at almost or just over about 0.5 millimeter a year. And this includes similar growth in both the virtual basal ring and sinotubular junction. And some of the factors that may increase the risk is more complex anatomy, whether there's a VSD included, whether it's double outlet right ventricle tetralogy type. Also, the male gender imparts risk towards dilation. And this also coincides with the risk of developing neo-aortic valve regurgitation following the arterial switch, with the freedom from aortic regurgitation being greater than moderate during the first 25 years, only being about 69%. And similar risk factors, complex anatomy, along with coinciding dilation of the neo-aortic root. And so with all this, about 5% of adolescents and young adults will require aortic valve and root surgery, often in their adolescent to young adult years. And this is the second most common indication following intervention on the right ventricular outflow tract. And so what are other risk factors for dilation? There's been histological studies showing diminished amount and altered distribution of collagen. The root has been shown to be less firmly embedded in the myocardium, and this risk is increased in the setting of a ventricular septal defect. And then there's important geometric differences that cause adverse hemodynamics and resulting tissue biomechanics, some that I'll get into. And then there's also still, I think, a question about the coronary reimplantation technique. And so we have a paper coming out soon showing how the rotational position of the neo-aortic root imparts risk for dilation, where the extremes of counterclockwise and clockwise rotation is seen by the imager, which is opposite to that seen by the surgeon, which we see much greater differences in following the arterial switch in transposition, shown here, where we can measure this by multiplanar formatting by MRI or CT, and we get these angles of -52 up to +78. We had established in a normal adult cohort with an adult cardiac group I work with in Kobe University in Japan that the normal values in adults is about -32 to +45 degrees. So much more extremes, and you can see in these graphs below, here the aortic root, here the ascending aorta, that at both of these extremes we have increased risk for aortic root and ascending aortic dilation. Along with when we have significant counterclockwise rotation, we have significant risk for developing aortic valve regurgitation. And we've shown this in a number of normal adults as a risk. We've shown this in patients with Marfan's, Louis-Dietz syndrome, and we've developed computational models with FSI showing how just the simple fact of the rotational position as we go from these normal variations in children and adults from about -30 to 30 degrees, that when we get more clockwise rotation, we have steeper velocity profile slope in the aortic root to sinotubular junction to ascending aorta, along with higher turbulent intensity along the shear layer interface, which means that we have increased wall and shear stress, and we have a risk and propensity for dilation of these thoracic aortic structures. And that's not to mention that we've described varying variability that correlates with the rotation of the underlying fibers versus muscular support, which also clearly impacts the structure and durability of the neo-aortic root. So looking into the different techniques for coronary artery transfer, recently an Australian group published their experience looking at these different techniques from the standard transfer to medial trapdoor to punch hole technique. And they stating that they prefer the punch hole technique, aiming to preserve the sinotubular junction. And I just want to point out one of the quotes from their paper that they mentioned that the coronary buttons are almost always transferred high into the neo-aortic root sinuses, and I bold sinuses here, where the valve attachments become narrow commissural pillars. And so their data showed no difference between these various forms of coronary artery reimplantation. However, recently a group from Korea published a similar study. They had a much higher prevalence of using the trapdoor method, and they showed that the non-trapdoor method had a much higher propensity for dilation than the trapdoor method. So I think that this is still up for debate. And we've seen some images from these different techniques in the coronary artery transfer, some showing the coronary arteries transferred in the aortic root, some shown high up into the ascending aorta. Here's the original drawing for Dr. Jatin's paper showing them going into the neo-aortic root. What Dr. Najim and I have seen with our valve surgical planning center with these patients coming for significant dilation, when I look at the commissural post and I mark out where the native sinotubular junction is, if this video will cooperate with me, well, I'll mark it out here. Here is right there is the commissure, and then as we look at the height of the coronary artery, I may have broken the system, but our coronary arteries are seen much higher into the proximal ascending aorta. So we do think that there is a risk for the height of coronary artery implantation and how that may change the hemodynamics and the resulting tissue biomechanics. So what are the indications for surgery for neo-aortic root dilation? And so in the literature, there's no reports of aortic dissection or rupture. Though many surgical papers, the surgeons will describe that when they go in for replacement and repair, they notice these very paper-thin, fragile walls. So when should we operate? Should we use adult guidelines at 5.5 centimeters in our older adolescents or children? How do we interpret Z-scores? To be honest, I'm not really sure. But if we look at a recent paper published in the adult literature looking at patients who had dissection with non-genetic predisposition for dilation or no genetic cause, they showed much lower absolute values of both the aortic root and the ascending aorta of patients who had dissection. So I definitely don't think that these neo-aortic roots are more durable or stronger than a normal aortic root. So I think we need to take that into consideration. So the second part of my talk, and we'll briefly get into how do we personalize neo-aortic root surgical planning. So we've heard some debate about echo versus cross-sectional imaging, and I'm going to hopefully emphasize the value of three-dimensional imaging with multiplane reformatting, where we can get very precise with quantitative assessment of various structures. And so when we have a patient coming for neo-aortic root dilation, we'll often use a combination of multimodality imaging, including three-dimensional echo and MRI and CT scan. And what I want to highlight here, when we look at the annulus or the virtual basal ring, and when we look at panels E and H and an analogous long-axis view seen by echo, and we correlate that to how we're cutting the ovoid shape of the virtual basal ring, you see that we're cutting this in diastole when it's very ovoid in a very oblique, almost nonsensical way. And that makes sense when you're getting on these two-dimensional echoes very variable measurements from one echo to the next of your aortic annulus. And if we take the TAVR experience and we use multiplane reformatting, we get into the short axis, and I have a ghost image of the aortic root over top in a surgical view, we can accurately measure the circumference, the area, the major, and the minor axis. And especially when we're evaluating the incompetent valve, we want to understand the virtual basal ring dimensions when the valve is trying to establish competency or in diastole. And then if we look at the aortic root, there's multiple ways to measure by multiplane reformatting with some similar terms. So here I prefer the top terms to be very specific, since two are called cusp to cusp. But what I want to highlight is even using multiplane reformatting with cross-sectional imaging, we can get highly variable values. You see here from 33 to 34 to 39 millimeters, depending on the method that we're using. I could go on what my preference is and some of the three-dimensional volume data that we have and how that correlates to these. But I think most important is that there's institutional consistency and that it's reported. So across institutions, when patients are being followed, we know how these roots are being measured. So what we've been working on is really understanding the valve substrate that the surgeon has to work with, being the leaflets, and understanding the three-dimensional geometry of the aortic valve, the leaflets, the sinuses, and the interleaflet triangles. Hans Holcomb Schaefer is an adult surgeon in Germany, has really led the way forward with this geometrical approach. But noticing that we had no normative values measured in a normal hemodynamic state, we went forward with this collaborative group in Kobe University in Japan, and we established these different metrics: the free margin length, the geometric height, which are measures of the leaflet substrate that the surgeon has to work with, the commissural height, the effective height, and the coaptation length, which are measures of effective coaptation. And more importantly, we demonstrated, when we look at the different planes from the virtual basal ring to aortic root to sinotubular junction, that there's a predictable relationship demonstrating that the normal aortic valve demonstrates physiological compensation to maintain optimal coaptation, hoping that these values could provide somewhat of a benchmark for the surgeon trying to restore valvular competency. So very briefly, we don't have time to get into the weeds of our approach, but these different measurements, the effective height, this is a measure of coaptation. And to accurately measure this, we have to use multiplane reformatting. We have to get into the center bisecting plane. And it's a measure from the virtual basal ring up to the central point of coaptation. And in adults, on average, it's about 8 to 10 millimeters. The coaptation length, if we look at the zone of coaptation, and this is something that we've delved into a lot this past year, it's a very complex three-dimensional structure. It's comprised of the nodules of Aurantius and the lunules on either side of the nodules of Aurantius. And if we, to standardize this measurement, the coaptation length, it's measured centrally, again, only obtained with the center bisecting plane, and on average is about 3 to 4 millimeters in adults. So the geometric height and free margin length, as mentioned, is the substrate that the surgeon has to work with. The geometric height is a measure of the midline from the lowest attachment point or nadir of the leaflet up to its central free margin tip. The free margin length is just that, a measurement of the free margin. And using this, we know in adults that the geometric height of greater than 20 suggests a leaflet length is sufficient for repair. And then lastly, the commissural height, which in a normal trileaflet valve, all three interleaflet triangles should come up to the plane of the sinotubular junction. In various forms of congenitally malformed aortic roots, then we'll have hypoplasia of that interleaflet triangle and resulting lower commissural heights. So we can apply this to our elementary school math. We can put this into the Pythagorean theorem. We can use the leaflet substrate that the surgeon has to work with, the geometric height, and we can say what we want the coaptation length and effective height to be, and then we can use that to help guide us what the annulus size, and this can really help us too when we try to determine graft size in valve-sparing aortic root replacement strategies. So at the Cleveland Clinic, we again use a very heavy multimodality approach with our surgeon's inspection being part of that approach. And we get preoperative CT planning using multiplane reformatting with three-dimensional reconstruction. We're creating computational models, hoping to be able to simulate and predict valve repair durabilities. And then we rely heavily on intraoperative imaging and intraoperative inspection. And I am very much a proponent of CT. With our newer dual source scanners, we can have very minimal radiation exposure, high temporal resolution with still considerations for radiation, but much more higher consistent spatial resolution than we often can get with standard echo imaging. And so just to end, I'll discuss two cases, one of transposition, one of congenitally corrected transposition. This is a 16-year-old with transposition arterial switch who had neo-aortic root dilation. We can see by the echo, no question, severe regurgitation. And then you can see the quality of our two-dimensional imaging. So any kind of three-dimensional echo, as has been said, garbage in, garbage out. So before we went to the operating room, we got a CT scan, a four-dimensional CT scan, and then make all these different measurements. I make these kind of reconstructions to highlight to the surgeons what the anatomy that we're dealing with is. So if we look at this, again, I can mark out the native sinotubular junction based on the commissural post. We see that these coronary arteries were reimplanted significantly high relative to that, which has caused effacement of the sinotubular junction. We not only have circumferential dilation of the root and the leaflets, but the commissures are also being pulled upwards. There's longitudinal dilation, something that needs to be taken into account with the repair. And then when we look at the different metrics of the leaflets, if we look specifically, the non-coronary sinus is asymmetrically enlarged along with its leaflet. We see, though, it has a shorter geometric height. This is almost an adult-sized patient, so it's a somewhat retracted leaflet. The right coronary leaflet measures 12 millimeters, also retracted. We see that that retracted non-coronary leaflet that's dilated also has a very low effective height at 4 millimeters. And then also important when we relate this to the very ovoid shape of the virtual basal ring with this significant rotational position of this root, so from a surgeon standpoint, it's significantly clockwise rotated. Then we see how importantly these two dysfunctional leaflets, the non and the right that are primarily the issue, are in the minor axis of the virtual basal ring, meaning that if we take a graph that is smaller than this major dimension, but is longer than this 24 millimeter minor dimension, we may actually stretch that out and cause more harm than good. And then case number 2, this is a 19-year-old male with history of congenitally corrected transposition, arterial switch, had LVOT membrane resection, modified mustard with IVC to tricuspid valve baffle, bidirectional Glenn, who has sought multiple opinions around the country for severe neo-aortic regurgitation and aortic root dilation. So you can see from the left-hand image, there's this extremely dilated neo-aortic root, and you can get the sense from the interleaflet triangles where the native sinotubular junction is. And if I make that translucent, and you can see the leaflet attachments and the commissural post well below where this coronary artery, where they're implanted. So again, implanted very high, that's led to effacement of the native sinotubular junction, dilation outward and upward. We see severe dilation from the virtual basal ring through the proximal ascending aorta. This is a trileaflet valve, but very asymmetric with this right-facing leaflet much larger than the anterior left and the posterior left. When we look at the virtual basal ring, we can compare it to the rotational position of this root, which is extremely clockwise rotated from an imager's perspective. And then we can pay attention to where these coronary arteries are for the replacement, the repair strategy. And then understanding these different metrics, we can again see this lower geometric height for this posterior left-facing leaflet and relate how this is in that minor axis of the virtual basal ring and use that for a very quantitative approach and personalized approach towards valve-sparing root replacements. So I'll end there. So in conclusion, progressive neo-aortic root dilation, valvular regurgitation is common in the decade following the arterial switch procedure. About 5% of patients will require intervention, and a personalized approach with advanced cardiac imaging may better provide the blueprint for valve-sparing or valve-preserving root replacement strategies. So thank you.
Thank you, Justin. And I would like to invite back to the podium Dr. David Barron from Toronto to talk about management of the neo-aortic pathology.
Thank you. Thanks, Ram. Yeah, I'm conscious everyone's going to be hungry. So, we've heard a lot today. So hopefully this will tie a lot of it together about what we're going to expect with a neo-aortic route, and just really to praise Brad's talk for, as you said, you could spend 5 hours talking about the long-term outcomes, but I'll try and do it sort of in 15 seconds. But the outcomes are outstanding, right, for the arterial switch. It really is a huge success story, right? Quality of life, although as Brad was saying, that there are issues, but this was a study which actually showed very good quality of life, and pretty normal development. And really, we could say, well done, pat on the back, problem solved. There isn't a problem. What's the big deal? But as we're learning, and again, we're learning. It's perfectly fair that we're learning, because we don't know what happens to people who've had a switch 50, 60, 70 years down the line, because this is the new population, and we're obviously reaping the rewards of a very successful neonatal surgery that never used to exist. But there is no doubt that the aortic root is dilated after an arterial switch, whether it's TGA or congenitally corrected. And we all recognize these sort of appearances of the aorta. It's pretty typical. And we see extreme cases too. So we know aortic root dilatation is an issue. And actually, looking at the data that's out there, it's remarkably consistent what several centers have published in terms of what you see with the aortic root and growth and progression over the years. And you can see in this study from CHOP, Merrill was one of the authors. The nomograms are there, the black lines, and they're superimposed the patients who've had an arterial switch. And you can see that basically there's no doubt the aortas are bigger, they're a bit dilated, but actually they do generally follow the normal growth curve. So it doesn't seem to be too much for kind of pathological or progressive dilatation, but you do get these outliers with significant dilatation. Again, then here from Boston. So look at the aortic root Z-score. Pretty well everybody starts out with a Z-score +2, but generally as the child grows, it kind of stays like that. So on the whole, most of these patients just have a bigger than normal root, but it grows at a fairly normal rate. And in terms of how that then translates into reoperations, and you look at, this is a sort of Mayo study, so really adults after the arterial switch, and looking at what they need to have done. Most re-interventions are really on the right side of the heart, usually on the branch pulmonary arteries or on the pulmonary valve. But actually the next most common thing is interventions on the aortic root and the aortic valve. So it is an important part of what we're going to discover. I mean, as we say, we're almost certain we're going to see more of it as the time goes by. So again, here's an adult study from Leiden in the Netherlands, looking at a really big population of people who've had an arterial switch right out, to 25, 30 years post-switch. So helpful to see, and again, pretty consistent sort of results. And they were looking to see really whether there's a difference depending on the morphology of your lesion. And you can see that there's not a huge difference, but those who had a VSD on those, particularly the green ones are the DORVs, the sort of Tausig Bings, are most prone to aortic dilatation. And particularly with the Tausig Bing, I think we could all recognize that, because we know there's a big mismatch in the size of the pulmonary artery, or what will become the neo-aortic root in the Tausig Bing, compared to other varieties of transposition where we do a switch. So for sure, it seems that they're more at risk. Maybe, if you have a VSD, there's a bit less support for the fibrous ring of the aortic root, and that predisposes them a little too. And again, so the same study, but here, how does that translate into freedom from aortic regurgitation over time? So mild aortic regurgitation, or a bit more, is actually quite common. And again, it's worse in those who've had a VSD and a Tausig Bing. Freedom for moderate is a bit more reassuring. You don't see like moderate or worse regurgitation very commonly, but it's still there, right? And again, I'll show you that's really been repeated in several sort of published series. And certainly, you know, the more your aortic root dilates, that translates to a bigger hazard of aortic regurgitation. Justin was just speaking about this, so trying to unravel what the risk factors might be. I mean, part of it, I think, is simply part and parcel. It's just the natural consequence of doing a switch in a neonate is you end up with a big root. So that's always going to be the case, but actually the reintervention rate is relatively rare. Certainly, so it seems to be commoner in VSD, especially Tausig Bing. Commoner if you've had a previous pulmonary artery band, and commoner if the switch is done at an older age. There's this debate about, does it relate to the actual surgical technique? So the trapdoor technique or the J incisions, so they disrupt the sinotubular junction. So in theory, that may predispose you to more aortic valve incompetence, but it's not shown in every series by any means. But as Justin said, this idea of maybe punching out a defect for the coronary may preserve the integrity of the sinotubular junction and so protect you from aortic regurgitation. But we don't know, that's only speculation. And I use a trapdoor because I feel it's the most secure way of getting a really good coronary reimplantation, and that is obviously your priority at the time when doing the neonatal switch. So again, you know, freedom from actual need to reintervention is very good. Again, Leiden study, I think over nearly 400 patients over 25 years and only 12 aortic reinterventions. So certainly at the moment in our populations, it seems that the intervention actually is very low. So 8 of them were aortic valve replacements, 4 were repairs. So it's a mixture of interventions, and we'll discuss in a minute whether we should be trying to repair these valves or just replace them. And this was actually a study we did when I was in Birmingham, looking at all of our switches and going back to actually the original echo when they left the operating room. And it's interesting to see that firstly, you know, your freedom from significant regurgitation is pretty good. But once we get out to about 15 years, there's kind of an inflection point, and it seems that when you start to get out to 20, it is getting more common, and that's why we were saying we don't know what's waiting for us down the line. Maybe we're going to see more and more aortic regurgitation. But this was the reflection of what the AR or the aortic regurgitation was when you left the operating room. So if there's none or it's mild, or if it's moderate, you can see the difference. So if you've got moderate regurg after the switch, you're pretty certain these are going to come back to you with severe regurgitation, you know, within the first 5 or 10 years. But even if it's mild, there's a significant progression, much more so than if you come out of the operating room with no regurgitation. So even then, you're predisposing the patients to regurgitation. And I think we need to think when we're doing the switch whether there are ways to correct that in the operating room at the time. This is age. Yeah, so this is a simple look at the age that the switch is done. And if the switch is done at an older age, the risk of subsequent aortic regurgitation is significantly higher. And that brings us then to the question, really, all of that data really is about regular transposition, D-type transposition. And of course, how does that translate to the double switches? Well, the double switches generally are much older. They're not neonates. They're much older, often several years old when they have the switch. They've very commonly got a VSD, and they've very commonly had a band on. And we know all of those are risk factors for subsequent aortic dilatation and aortic regurgitation. So we know they're at risk, and that is the case. So aortic regurgitation is higher in the CCTGA group after the double switch compared to the regular D-type transposition. And this was some of Ram's data from Boston, looking at this is the cumulative events, and survival fantastic, over to 95% at 10 years. But this was the instance. The red line is the need for aortic intervention on these patients. So it was the commonest need for surgical reintervention in this population, and that's been shown in other series. That was my series in Birmingham, where we had, again, sort of around about 10% aortic regurgitation in the population out at sort of 20 years, from Bonn, 10 to 15% at 20 years. So it's commoner, clearly, in the CCTGA group than it is in the transposition group. And I suspect that's not because the morphology of the valve or the technique of the switch is different. It's because they're done at an older age, and they pretty often had a band done or got a VSD. So can you do anything about it? Well, certainly we took on this sort of approach that if we would measure the aortic root or the annulus size at the time of the double switch, and if it was like a Z-score +2 or more, then we would perform an annuloplasty. So actually would place like a Hagar dilator through the valve and put a double sutured ring suture annuloplasty around the root, just to try and cinch in the root a little bit to try and reduce that risk of aortic dilatation. And for this, it was only in a small number of patients, but out at 8-10 years, we didn't have any regurgitation in those patients, so it did seem to help a little. And similarly, this was came out from Fu Wai a few years ago, looking at both their regular transpositions and congenitally corrected, and they undertook this sort of policy of where the root was really big, the near aortic root, by which they said like 2 to 1 side diameter bigger than the aortic root. They would kind of prophylactically perform a sort of resection and plication and the size of their neo-aortic root at the time of the actual switch. And again, at a relatively short follow-up, they weren't seeing any aortic regurgitation. So there may be things we should be thinking about doing at the time of the switch to try and reduce this risk. In terms of what to do, obviously, you're faced with different sort of pathologies, and quite often, you do find abnormalities in the aortic valve leaflets themselves. Here, this is just from some of the things you might consider doing. So here you've got a prolapsing leaflet, and the leaflet free edge has got extended. So sort of leaflet plications and resuspensions may help in certain cases. If you've got particularly an asymmetrically dilated root, taking out a whole piece of the dilated sinus and repairing it like this may help, or even placing an annuloplasty ring around the root under the coronaries. That's not easy to do. You've got to really free up the root and get underneath the coronary buttons to do that often in an adult. That's not necessarily so easy, but these are all things that have been described. In terms of the root itself, well, you've got to decide if the root needs replacing. As Justin's saying, we tend to go with standard sort of adult guidance. So if the root is kind of reaching 55 mils, that's normally the trigger to recommend a root. And you have to decide whether you think you can do a valve sparing root, a David type operation, or whether you'll just do a straight Bantle. And certainly, I think if the valve looks to be structurally normal with 3 healthy leaflets, it's always nice to be able to do a valve sparing root. But I think you have to be confident that you can get a good result, because as Chris was saying, it's not an easy surgery reoperating on someone who's had a switch. As an adult, you've got to take the whole Lecomte maneuver apart to get access to the root. You've got to be aware of the coronary buttons and trying to really mobilize around the aortic root when they've had a switch, and you've got patchwork in the pulmonary artery is actually is quite a surgical kind of challenge. And so I think if you're going to commit to a valve sparing root, you want to be pretty confident that you can really get a good result. You don't want to be back again a few years' time because the valve is leaking. And just a sort of final comment, this has been described as well, that if you've got maybe a very abnormal aortic valve and the pulmonary valve is healthy, you can even kind of do a switchback, a kind of reverse Ross procedure. So I think, as a summary, dilation is certainly the norm. And the majority of it is relatively benign. It seems to be kind of very slow, but slow growing, and grows along the kind of growth curves for the patients. But it is an issue, and it looks like at the moment about 5% of patients may need some sort of neo-aortic reintervention at 20 years, and we know that these are the risk factors, as we've said. And it seems to be more of a problem actually in the double switch population than it is in regular sort of neonatal switch surgery. So maybe we can do something preemptively to reduce the incidence. But for sure, for the future, we really don't know what the future is going to hold. And we really, as everyone has repeatedly sent a message out, I think this morning, we have to make sure we're really following up this adult population really carefully. I think we'll see more of it. Thank you.
David, stay on. I know everybody wants to go for lunch, but we had really great speakers, and at least so please have very quick questions to the speakers. I want to have this speaker come up so we can have them quick questions and quick answers, because it's just fair. It was just an incredible session. So let's have some discussions.
Yeah, I got a quick one that I'll ask while people are getting ready here. What about the patient after a switch for either transpo or congenitally corrected transpo that's got dilatation of the neo-aortic root in the absence of any other problems? So it's just growing and growing. What's the criteria for intervening on a dilated aortic root without AI, without neo-AI, but getting big to the point where if it was a virgin chest, nobody other problems, you would probably do something to that aneurysm? How big, in other words, how big would you watch it after a switch before you did something? Ron?
Oh, that's a great question. I think that's a big dilemma. I think we don't, as many people have said, we haven't really seen the threshold at which we see some of the complications, such as dissection or rupture. And I think that's something that drives it. But Dr. Svensson.
Well, here, Doctor, when I asked the question, I didn't even realize the authority that we had standing in the room here. So I defer to Dr. Svensson.
So we had a big discussion. This microphone isn't working.
Can we turn on Dr. Svensson's microphone?
All right, there we go. At the aorta meeting, the AATS aorta meeting about this, and particularly we talked to Cameron about the indications after a switch. And we generally agreed that 5.5 was probably a reasonable size, because neither of us in our institutions had seen any aortic dissection in patients with transpositions, although 6 months ago, we had a patient who dissected about 5.3 centimeters.
After a switch?
After a switch. So it does happen, but it's fortunately pretty uncommon, and it's impressive what the rate of reoperation is for dilatation. As you saw that one study, out of 12 patients, essentially 6 required a reoperation for dilatation. So it's rare, but be aware that it can happen.
I remember Duke saying that he'd never seen a dissection after a switch, and that he said he wasn't going to rush into operating based on a Z-score or a root size, because it was he had never seen that happen, but I guess it could.
I've done 2 or 3 that have been in that 5.56 centimeter size.
I just had a question for Dr. Imamani. I think, if I'm not mistaken, in the Boston data, the previous pulmonary artery banding was actually protective for neo-aortic reintervention. Is that? Can you comment on why you think that's different from other studies?
Yeah, I mean, it was the age of banding that actually made a difference. So, the patients who had a later banding had a higher incidence compared to those who had banding at a younger age, and I think we see it sometimes. The patients who come later have already a thinner pulmonary annulus, neo-aortic annulus. So we can see it when we're going to do the arterial switch. So I suspect that it has to do with how the arterial wall remodels, and that may be somewhat time dependent, age dependent.
So practicing in a setup where you see the spectrum of patients, like the Cleveland Clinic, from babies all the way to the adult life. It's so sobering to see the data that Brad has presented in terms of the late outcome for those patients who had a coarctation versus others. Obviously, this is related to the neurodevelopmental outcome. And I have to say that it is sobering to see. So every time we go through a decision, sternotomy versus thoracotomy, any study which looks at 10 or 15 years of data is worth nothing, really. It is what they do later on in life and what happens to them. It is impacting them. And every time we say, oh, let's just do a sternotomy because we could do a better co-arc repair, you're paying the patient is paying the cost of this circle rests from the front later on in life. So do you want to elaborate on this? And every time, it's so sobering to see this because we just take this very lightly when we say, oh, let's just do a sternotomy because we can do a better co-arc repair. You got to weigh this versus 1 or 2 dilatation possible or may not for this coarctation repair versus doing a thoracotomy and avoid the circle rest.
Yeah, Hani, this is such an important point, especially where, we think it's just coarctation, right, with arch hypoplasia. Having the newborn brain go under bypass is not for free. And if you can do it from the side with an extended end-to-end, I'd much prefer that you do that than put a neonate or an infant on bypass unnecessarily. And I've worked at centers where surgeons did arch advancements on kids that I knew that other surgeons I worked with could do it from the side. So, the data is sobering. And I think as a team, we have to understand that what we do to these babies in this first couple months of life can have a dramatic impact on what happens to them when they're children, teenagers, adult congenital patients. So I think the surgical planning that we do, all of us together, surgeons, anesthesiologists, cardiac intensivists, cardiologists, fetal docs, the path that we put them on is decided right then.
Well, so let me follow up. You showed data in your talk that the neurodevelopmental outcomes of switch VSD is not as good as isolated switch. You think that's just because the bypass time's longer, or?
I think it's a combination of bypass time being longer for most surgeons.
Or different protoplasm, or?
No, I think the bypass time is longer. I think a lot of these VSDs also have outflow tract obstruction. And then they have a second operation, a third operation. Remember, every time you do bypass, second, third, fourth time, the brain's getting inflamed. And, my quality of life data shows very specifically, the more interventions you do, the more hospitalizations you have, the lower your quality of life is. And I think it's completely directly related to, obviously, the complexity of the disease and what happens relative to your brain. What I love working with surgical teams that think very discreetly about what they're doing, why they're doing it, to minimize future interventions. And I think, Chris said this earlier, do it right the first time. It's so important.
It was in big, bold red on her slide.
Do it right the first time.
Yeah. Just send a question to you also, and I'm so happy that you've highlighted the difference between what is the perceived ST junction in a transposition versus the actual ST junction. And that's why I changed my technique I do a closed technique for the arterial switch, so I do the distal anastomosis, so my coronary buttons never reach the distal anastomosis. I wouldn't say it doesn't reach the ST junction. The distal anastomosis is not the ST junction, but when you look at the CT scan, it looks like the ST junction is up, but it's not. It's actually where the top of the commissure is there. And now we're seeing again the spectrum of those patients. So any follow-up, and Justin showed me that paper with 6 years follow-up. I said, this is useless. We see them in the adult side, and the adult side, when they come at 25, 30 years later, Lars sees them also. This is what they are. They are different. So any study which looks at the technique versus dilatation that follows for 6 to 10 years is useless, I would say. It's what we see them in the adults. They're completely different patient group.
I feel like this is when my kids tell me that they brush their teeth and then their breath smells and I see their teeth are all fuzzy. Because when we're looking at these roots with significant valve regurgitation, the coronaries, even though all the diagrams show implanted in the sinuses, we see them way up. And I asked Diane the heart specimen she has, and she has one with it high up, one down. So that's what you and I have had discussions, that this is a potential modifiable surgical technique if there is leeway without kinking of the coronary arteries to try to keep the sinotubular junction preserved. And because that clearly changes, we'll do computational studies, we'll look at the hemodynamics and tissue biomechanics, we'll see exactly what we're seeing in the anatomy, that there's increased wall stress where we put those buttons. The bigger the buttons are, the more we'll get eddy currents there, putting stress that's going to lead to dilation, lead to effacement. Well, we have to better understand that.
Well, Justin, A, that's a great answer, and B, the toothbrush analogy, I think, is something that we'll all take home with us. Let's take one final question from Professor Chuck Fraser over there.
It's actually a comment. I just can't.
Perfect.
I can't contain myself.
I saw you sitting there, and I knew that it was inevitable.
Is it about
that
the
you, it's about the cohort. It's about cohorts.
I've been pretty good. I've been pretty good today, but
This is your.
So, Brad, I just can't accept what you're saying. I can't accept it. For you to say to this group that the number of bypass operations as a singular variable predicates your neurodevelopmental outcome is not proven. It is a complex, and my counter response is, if we do a bad operation in a baby, it's not true that surgeons can do the same arch operation through the left chest. Sometimes we can, but not always. And we set the stage. We're making plenty of work for Lars, plenty of good work for Lars. And I think, just 5 years ago, we were talking about the number of volatile anesthetics. What's happened with that?
So Chuck, to be clear, I didn't say it was the only thing.
Good. Good.
Because
what it does is it gives people an excuse for bypass doesn't matter. You put a little of this in, you put a little of that in, you turn the pump on, you got to operate fast. We know that that's not true. There's bypass and there's bypass. We have to believe that we can provide physiologic support, or we shouldn't do ECMO.
So, Chuck, there's something as simple as when all my surgical colleagues up here are in the OR, you have no idea how you're perfusing the brain. You have the perfusionist set a mean arterial pressure. You have no idea what the cerebrovascular resistance is. You have no idea what the flow is. If we could actually measure, and this is what Ken Brady, who you know very well, and I and Blaine Easley are working on right now, we're actually going to measure the lower limb of autoregulation in the cardiac OR and in the ICU to make sure that we decrease the hypoperfusion dose in millimeter mercury minutes in all these babies. So we've got a pilot study right now. That's an area where I think we can absolutely reduce the amount of brain injury just by decreasing the hyperperfusion dose. Now, imagine I've got 4 operations, right? And no matter how complex it is, there are going to be multiple operations, okay? But in each operation, I can decrease the hyperperfusion dose by 30%, by 40%. And I reduce the white matter injury with each one of those operations. I agree with you. The time is less important than how you conduct the operation. And right now, we don't know with all these pump runs, what is the dose of hypotension these brains are seeing.
You got to quote Dean Andropoulos.
Again, agree. But the goal should be physiologic bypass, minimize numbers of exposures. I say this in the same vein of the comment I made yesterday about the CT scan. Thank you very much, Chris. If you get an anesthetic for a CT scan and another anesthetic for an MRI and another anesthetic for a balloon atrial septostomy, and then you go to the operating room, is it the bypass machine?
Chuck, I completely agree with you. It's multifactorial. I completely agree with you. I'm just telling you what the data is showing with a lot of confounders and all the things we're talking about. What's hyperperfusion dose, the inhaled anesthetics, the plasticizers that we're giving these kids as neonates during all their operations. And we can go on and on and on. It's multifactorial. But when kids go on bypass, depending on how you conduct the bypass, some will have more hypotension than others relative to the brain perfusion.
Thank you for that clarification.
You're welcome.
Dr. Svensson.
Sorry, I can't leave this because I've studied this a lot in adults. And we've done neurocognitive testing, we've done brain MRIs pre and post. And I will just make a comment. We don't have time to go into this, but actually IQ improved after circulatory arrest. Now, that's a bit like the computer hitting the reset button, I think. No, what happened was patients were learning to do the IQ test. But the point is, when we compared it with coronary artery bypass surgery, the studies comparing coronary artery bypass with hernia operations, it's more or less the same. So it's not just as simple as circulatory arrest is bad or putting a patient on pump is bad. There's much more to it than that.
Yeah, and I think also we have to qualify that the oxygenators we use now and the bypass techniques that we use now is different than 20 years ago. So your data may change as you continue to follow your patients because we have gotten much better on
Although if you look at Bill Gaynor's ICON study, which was more than 10,000 children over a 20-year period, the IQ and the academic achievement did not increase at all over 2 decades.
Well, I think we've reached uniform agreement about all the topics discussed today, and therefore it's time to have lunch.
Chris, you want to comment?
We haven't mentioned one thing at all about preoperative and postoperative management of these patients where they can also be hypotensive, and you can, we don't image everybody going to the operating room. So I think you can have an operation with perfect bypass or, perfect circ rest, perfect antegrade cerebral perfusion, and you can hit the unit and have a, tank and blood pressure. Some of these kids are going cath lab to OR, and I think that's why it is multifactorial. I think we have to, I don't know that we're ever going to know, because to actually do that study, can we
Chris,
even do that?
That's when I give my talk, I said 1/3 of the kids walk into the OR white matter injury. Another new 1/3 of them walk out of the OR with new white matter injury. And that's why the study that we're doing, what Ken, me, and Blaine, we're looking at the hyperperfusion dose in the OR and in the ICU, because to your point, as a cardiac intensivist, there's no question that kids have periods of hypotension. And it could be the kid was perfect in the OR, but then in the ICU, our ICU teams did the best we could, but the kid had 3 hours of hypotension, and that's what injured the brain. It's multifactorial, but these are the areas we have to look to try and minimize the brain injury.
So again, we are in total agreement on all topics discussed today. Just before we go to lunch, a couple of logistics. We're going to start the breakout sessions at 2:15, so everybody has time to have lunch and continue this great dialogue. Breakout sessions will be at 2:15. At 6 p.m., we're going to have cocktails and posters, followed by our 7 p.m. dinner, where Dr. Svensson and Dean Cook from the University of Florida will have a fireside chat without a fire. So everybody, the posters will be fun. We've got some really good posters. Come to the posters, have a glass of wine, and come to dinner. Breakout sessions at 2:15. And Cleveland Clinic and University of Florida, again, have steak and lobster for lunch down the hall.